What I mean by epistemic communities are communities of knowledge-based experts. So this is a term that comes from philosophy, from epistemology. Um, so it basically means that experts come together, whether they be healthcare providers or researchers, and they form a community in which to help each other. And what we can see during the COVID crisis is what they were organized in a really informal and spontaneous manner, and it's really interesting via online networks, particularly blogs, WhatsApp messaging services, group emails. They really these new technologies really allowed them to form these epistemic communities very, very quickly. And at least at the end of our research period, they continue to be very active. They enable professionals to seek advice from colleagues, even about things that have nothing to do anymore with the COVID crisis. So maybe this wasn't new per se, but it was innovative in the context because it allowed a new means of interacting among professionals in ways in which there had been really limited coordination before the crisis. And it was used in particular by isolated professionals or those persons that were kind of isolated in their hospital, for instance, occupational therapists, and allowed them also to connect among professionals at a citywide level. So I find this probably the most interesting results to come from this was the ability to organize very quickly via social media and to seek advice from fellow colleagues. As you probably already know, there was a lot of new forms of interdisciplinary and inter-service coordination. As Maria, pharmacist, says, the crisis made room. It broke down a lot of organizational barriers. So a lot of these maybe are familiar in your countries and in other contexts, but in any case, the vaccination campaign in France, at least in the cancer hospitals, was quite well organized because of this new kind of interdisciplinary coordination between pharmacists, occupational physicians, healthcare volunteers, and it really allowed a fast and coordinated vaccine rollout, both for patients, for families, but also for healthcare providers. There was also, at the city-wide level in any case, there was quite a good coordination to transfer patients from a hospital service which was overburdened, or those that did not take COVID patients. And so it meant that sometimes care was not to be delayed. And so this was a really important factor in helping patients not to lose their chances of survival and treatment. And also, at least in the metropole of Lyon, there was quite a good coming together of interdisciplinary research teams to work on clinical trials for COVID during this time. And according to research assistants, nowadays, it allowed them to come together and to know the competencies. And so now to work on other projects, it's become more possible than it was before. There was also, I'm sure you also had this, was a lot of COVID reflection cells. It really allowed structures to be agile, at least at the management level, and especially because of teleconference technologies, which permitted interdisciplinary coordination between sites. So it really allowed an interplay between the field, I would say, and the management level, because they were able to have everyone's collective reflection and to adapt for this reason. Of course, I don't want to say that all was rosy, all was perfect. There's a lot of limits in this interdisciplinary coordination at the time. Especially, it was able to be organized really among the hospital, but it was harder to be organized at the city and the regional level. So one of the management professionals that I organized, he really stressed, and as you can see from this quote, he really stressed that the hospitals were all alone. He said, the hospitals were all alone. We decided for ourselves. This is a major lack during the crisis. Everyone organized by themselves. You can see in social science, when you see a repetition, this means that the participant really wants to emphasize that they were all alone. So he says we really need to organize differently. The good level is not the hospital. It's the region or the city, not just the hospital. Of course, you know about the telemedicine and teleconferencing that really came into focus during this time. It's really interesting interviewing different types of professionals because it really allowed to see the possibilities and limits according to each professional. So the pharmacists were some of the most interesting people that I interviewed because they said that it wasn't good for the first meeting with the patient. They really stress the importance of the relationship with this patient, but it was good for more common tasks like renewal of medication. When the patients can't come or lack the time to come, then they see a need for teleconferencing or telemedicine technologies. The surgeons as well, as a lot of doctors will say, I think the fact that if you have to break bad news, unfavorable outcomes about a diagnosis, about a post-procedure with the surgery, it's not a good idea to do telemedicine. However, the surgeons in particular said it's a really interesting way actually to be able to better communicate with the patient, because they can explain the surgical procedure when the patient is ready to receive it. So after the surgery or before the surgery, but in any case, this really allows them the time that they didn't have before. And I think this is quite well known now, but in any case, the idea that can reduce the burnout, the stress for both the patient and the healthcare provider at certain times, this is an option, which is interesting, and also can reduce some territorial inequalities, especially for those going to national reference centers, which are just in the big cities, at least in France, and so it can bring care and access to those outside of the country or the region. During the COVID crisis, there was even patients using telemedicine technologies in London, for instance, who wanted to interact with their healthcare provider in France. So that was very interesting. But of course, we have to think about the digital divide and who we're leaving out in this question, and notably how fragile patients may be further marginalized because of these technologies. So this is not at all to give a rosy picture, but it is quite interesting for these reasons for some patients. And finally, what I find also very interesting, because it's a subject that's coming up, it's becoming very important, is the idea of doing decentralized clinical trials. With the idea that will reduce costs, we can get electronic informed consent and things like this with patients without them having to come to the hospital. However, what I find very interesting is even if it's more cost efficient, most researchers, most clinicians do not want to practice this in a normal clinical research setting, because they thought it was very important to see the patient in person. And this is going to become a huge issue in the coming years, so it's really important to take these lessons from the COVID crisis. There was also a lot of creativities in the care plan. This was mainly the nursing perspective, which I find quite interesting because they're the ones that really focused on this. They focused on how nurses really practice new models of care. One started drawing comics. One used newspapers. They used drawings. They brought in instruments. So they really had the time during this special time, even though it was very stressful. And in some services, some of them were able to come back to their healthcare values and really practice nursing as they believed it was important, and in a person-centered perspective. And this has led to a lot of thinking, at least at the nonprofit private hospital, Lyon Boegard, which is continuing to this day, actually, and shows that they're rethinking the nursing profession and how to think about the quality of life, both for nursing professionals, for doctors, but also for patients. The second thing that I told you about, this wasn't a big theme, but in any case, it's worth discussing, is that there was some possibility to break down some barriers and to change things so that it could go better in a perspective, an ethical perspective of equality. So there was this idea of one service put into place a more harmonious approach, a consistent approach to treating similar cases, so that it could be the same for everyone. And this aimed to really improve the quality of care, but also decrease costs, because it reduced unnecessary procedures or scheduling, and led to a reduction in hospital stay. So that was something that only one or two services put into place, but had a durable impact. There was also this idea, it's kind of related to the harmonization of streamlining, the idea to refine procedures, to optimize planning schedules, which led to a clear plan of action for the patient. And for the professionals that were able to do this, they said that it led to more transparency with the patient, because it was very clear. They had, as this quote says, the day the patient comes to the CT, we know that he'll have a treatment 2 weeks later. We can be very transparent with him, and it's a very good way for both the healthcare professional to know exactly when the procedure will take place, but also for the patient to be able to plan. So as we can see, during this time, there was a lot of institutional agility. This is surprising. When we think of the COVID crisis, actually, they showed a lot of innovation. Healthcare providers and hospitals, as you can see from this quote from Mark, he says, usually we have this traditional picture of a hospital, which is a big thing, very difficult to move. And the COVID crisis shows that hospitals are much more reactive than they thought we were. We showed that we were able to adapt, to face very unusual situations. So this is a pretty good sign, and it means that hospitals were actually able to be more agile and to be more creative and to innovate and to change than we traditionally thought. So as we can see, these were relatively simple to put into practice. A lot of these innovations and changes, they were facilitated by technology. But in any case, both frontline and management staff showed that they were able to adapt, to be creative, to continue to provide quality care during the COVID crisis and in the post-COVID period. And as we can see from the nursing perspective, this was in coherence, in line with their own values. However, as we all know, nowadays, the healthcare sector is facing a huge crisis in terms of staff retention. And so this shows that it is possible to provide care in line with the person's values. If we think mainly of the nursing perspective, it's possible to be creative. But we need to work together. We need to have these reflection cells. We need to have these epistemic communities to work together and to feel good about being a healthcare provider in this perspective. So I think we should take what's positive from the COVID crisis and think about how to adapt and innovate in normal times as well. So thank you very much for your attention, and I wish you a good conference. Bye-bye.